Hello. This is the beginning of the Introduction to Quality Improvement slideshow, the first of 6 slideshows you will be getting over the next 3 months on how to do quality improvement processes. This is going to be a general overview of the whole process. I just want to make an important note before you go on that there is a handout that should have come with all of this. It's called the Commonwealth Fund Report, and I'm going to refer to it a couple of slides down, so you want to be sure and have it with you before you get started. There are 4 objectives in this particular presentation. First is to identify the need for quality and safety initiative, and then we'll spend a few minutes identifying problems with errors in healthcare, problems with quality, a lot more time talking about quality in healthcare, and then we'll describe some initiatives to improve quality and safety. In the year 2000, the Institute of Medicine published a book called To Err is Human, which was really the beginning of the contemporary quality and safety movement. The book was a national wake-up call and highlighted the magnitude of the problem of errors in this country and identified that as best they could estimate, between 44,000 and 98,000 preventable deaths occurred every year due to errors. And that in fact errors were one of the top 10 causes of death, medical errors, one of the top 10 causes of death in this country. This was a shocking expose, if you will, about errors and made us really think more about how we do healthcare. Although the To Err is Human literature, in fact most of the literature on errors in healthcare is limited to hospitals, the problems aren't. And there aren't a lot of studies about errors per se in hospitals. There are, or in clinics, I'm sorry. There certainly is a lot of data that we'll look at in a minute about quality. But I do have one reference here of an article that I was able to find that identifies medical errors that occur in primary care setting. The most common medical error that actually occurs in primary care is prescribing the wrong med or the wrong dose or the wrong route. And they're not really that uncommon in primary care. But most of the time in primary care we talk more about quality rather than errors. This is a slide where I want you to pull out the handout on the Commonwealth Fund Report. It's a 2-page summary of some of the things that the Commonwealth Fund, who does a report card about healthcare, not just in the United States, but in the world, every couple of years. And they really have a pretty awful report about the quality of healthcare in the United States. And for example, they note in the U.S. ranks 19th in industrialized countries in the number of deaths that could be prevented with early and effective care. So 18 developed countries, industrialized countries, do better than we do in preventing deaths with early and effective care. We have improved 4%, but most countries have improved much more than we have. In fact, 3 times that much or 4 times that much. Patient-centeredness, less than 50% of patients in this country could get a rapid appointment when they were ill. 73% reported they could not get after-hours care without going to the ER. We're always complaining about patients' inappropriate use of the ER, but 73% said that was their only option for after-hours care. And it goes on from there. We all know about the problem with uninsurance in this country, but perhaps more frustrating, or equally frustrating, is things like, if you go down to the bottom of that first page of the table, inappropriate, fragmented, and wasted care. 3 to 4 times the benchmark rate of patients report that they've had duplicate tests or that medical records or tests were not available at the time of the visit. Think about this in your practice. How often is something done another time because you can't find it, or the patient is there and you can't find the lab result you needed or the test result you needed? There's an inappropriate number of hospitalizations, and one of the most interesting things, and we won't even go into all the data about this, but the variation in quality of cost. And we know that in this country, that there are parts of the country, for example, Florida, where it actually cost, if you compare patients, if you hold everybody the same and you compare Medicare patients in Florida with, say, gallbladder problems, it will cost almost 50% more than it does at a place like Mayo's Clinic in Rochester, Minnesota. And so there's quite a bit of inequality that does not have anything to do with quality. So it can cost more and not get you better care at all, as we all probably already know. Here's some more data on quality in the United States. This is a little bit older, but it's probably just as accurate. A RAND study in 2003, it was published in 2003, said that less than 55% of people in this country received recommended preventive care, or recommended health care. Same number received preventive care, things like their pneumovax and their flu vaccine and pap smears and all of those kind of things. 53% received recommended acute care. This is just over half are receiving recommended things. 56% received recommended chronic care. 52% received recommended screening. Under 60% received recommended follow-up care. And significant variation on the conditions. For example, 78% of people with senile cataracts actually had good care compared to 10% of people with alcohol dependence who met quality standards. And I'm not saying that people with cataracts, what I'm saying here isn't that alcoholics didn't get good care. It's that people with alcohol dependence didn't get the care they should have gotten. Whereas 78% of people with cataracts got the care they should have gotten. There's probably a lot of interesting reasons for this, but the point that I want to make is that there are problems with quality, not just error. And that really takes me right into the next couple of slides, because I want to talk briefly about the concept of error, because we tend to think of errors as mistakes, something we do wrong, but I want you to think of it much broader than that, because an error can be diagnostic. It can be a delay in diagnosis, or the wrong diagnosis being made, the wrong diagnostic test being done. It can be an error in treatment, either an error in the performance of the correct treatment, but it could also be an error in the choice of treatment. And it could be something as simple as using the wrong type of medication for a person with type 2 diabetes. And errors that could be preventive, a failure to provide preventive treatment or follow-up is a medical error. Failure to communicate, and equipment failure. So there are a very broad range of errors. It's not just giving the wrong medication the wrong way to the wrong person. Much more complicated than that. But they're all still errors that have a significant negative impact on quality. You know, this is a factoid that came to my awareness about a decade ago, and it really troubled me, and I've sort of tried to watch myself when I'm in practice since then. It says here, and this is very interesting because I want you to think about how we make mistakes and how we catch mistakes. Because it's what it says, that most healthcare workers make 5 to 10 errors per hour. Now you're all saying, wait a minute, there's no way I make that many mistakes. But think about how often, if you're a healthcare provider, that you start to write the wrong prescription or you write the wrong dose. You catch it by yourself. You start to record the wrong time in a patient's appointment. Just write the wrong number somewhere. So most of these things that we start to do, we actually catch by ourselves. Another 20% are caught by somebody else. So for example, if I write the wrong medication, or if I write it for a prescription for a medication the patient is allergic to, the pharmacist might pick it up. Or I get calls from pharmacists, fortunately not very often, but when I do, it's often saying, did you really mean to write this? Did you know the person was allergic, or is this the dose you want, or I want to clarify? So that's how some of the errors are picked up. And another percent are recovered by system checks, such as the computer software. And if you have electronic health records, you know that sometimes they'll pop up and say, danger, danger, you can't give this medication, or this person is allergic. So these are all ways that we catch errors. So the vast majority of errors never happen. They just are things that started, but we catch them at some point. I'm going to show you a slide in a few minutes about how we catch them. So one of the things that's happened after the book To Err is Human came out, one of the points about quality is that there are some areas of gaps. And if you have much to do with hospitals, especially large hospitals, and you all probably don't, but large hospitals particularly that go through accreditation, spent a lot of time working with quality issues because of JCAHO and other mandates. But in ambulatory settings, especially in small clinics, there's been a real gap. There's no external motivator to do quality work in ambulatory settings. This is aggravated by the fact that there really isn't a lot of education in primary care, preparing primary care providers or nurses in how to do ambulatory quality in ambulatory settings, and there's been very little work on how to do quality work with vulnerable populations. Some other things about quality that are gaps, if you will, is we know that really chronic illness is the priority condition, and it accounts for the majority of health problems and health burden in this country, and certainly the cost of health care, and it should be, therefore, the focus of an intensive intervention. And I've got a list there of some of the diseases that are health problems that are considered priority conditions for doing quality improvement. And I've got 3 of them highlighted because you all are really involved in a project that's about diabetes and heart disease. And I should have highlighted hyperlipidemia there, plus I've got my colors a little off. But anyhow, you can see the diabetes and then 3 parts of heart disease, hyperlipidemia, hypertension, and ischemic heart disease, are listed in those list of priority conditions that have been identified. One of the things that came out in that book, Crossing the Quality Chasm, was this idea of old healthcare rules and new healthcare rules. And I hope you get a copy of the slide presentations. You can make notes and look at these so that you have some time to think about them and think about what rules you tend to operate over and whether you're thinking old or thinking new. For example, in the old healthcare thinking, information was a record, a patient's record. In new healthcare, knowledge is something we share, and information is something that flows freely between the provider and the patient, between electronic systems. In the old system, decision-making was based on training and experience, whereas in the new system, it's based on evidence. So, that can change from day to day as there's new evidence that comes out. In the old system, doing no harm was an individual responsibility, and that's not to say that we all aren't individually responsible for doing no harm, but what we know very clearly now is that safety and quality is a property of systems, not of individuals. It's not about unsafe individuals, it's about unsafe systems. It's terribly important to remember. I'll go over that again. It's not about unsafe individuals, it's about unsafe systems. A few more rules. Secrecy is necessary. I remember years and years and years ago, a physician that I worked with, I said something about telling a patient what his blood pressure was, and the physician said, well, you should just tell him it's okay and that you're in charge and he doesn't need to know his blood pressure. And that's really old thinking. That was a long time ago. But now transparency is necessary, and we really need to be open and to get our patients involved. Patients should be at the center of things, and things should not be secret. In the old system, the system reacted to needs, and now we really need to anticipate needs. Just like when we're caring for young families, we try to anticipate the next developmental step that any child is taking when we're working with parents. In the old system, we're trying to reduce cost, and that's not a bad thing, but what we need to do in the new system isn't worry so much about cost reduction, but decreasing waste. There's just so much waste, just time, information. We talked earlier about the idea that, sometimes tests are done. In my clinic, I sometimes find that I've got students that come in and they will have ordered an A1C test every month because they just can't seem to find the last one that was done, even though it's right there. And so that's just a waste of money. In the old system, preference was given to professional roles over the system. And in the new system, it's about cooperation among all the people. And it says here among clinicians, and that's certainly a priority. But it's about the entire team, and you'll hear me talk about that in a few minutes. This is not about providers, it's not about patients, it's about everybody. It's about a healthcare team. The front desk and the finance person are every bit as important as the clinician in this process. So what I just said is sort of a segue to the 4 core principles of quality improvement. And they're right here, and I'll go over each one of them in more detail. The first is that it's about systems. It's all about systems, and then it's all about teams. It's not about individuals. It's about the system and about teams, and then it's about information. It's all about data. So you don't know that you're doing well or that you're not doing well unless you have the data. And that's what this project you've been involved in for the last couple of years has been about. You've been getting the data, and this piece of it is about, okay, let's make sure you understand what to do with the data. And that gets into the ongoing quality improvement processes that we'll be talking about over the next 3 months. So I'm going to talk in more detail about each of these. So we talk about system level interventions, and here are 5 examples of them. The first is policies. So you have policies about how to, and procedures, really they go together. I've never really been quite sure what's different about a policy and a procedure. Maybe you all are better at that than I am, but it's just rules about how to do things that you can share so that everybody knows how something is done. And so that if you or I, God forbid, were to drop off the face of the earth tomorrow, there'd be a policy or a procedure somewhere that somebody could pick up and know how to follow. And that we were all doing it the same way, which was the right way. And then building in redundancies. So, for example, the pharmacist checks a prescription just like I write. I write a prescription, a pharmacist checks it, and hopefully the patient checks it. So building in redundancies that are sort of double checks. Accreditation is an important part of system quality improvement, and that's, as I mentioned earlier, really the disadvantage we have in very small practices like yours, where there isn't, you really, I'm sure none of you would want to have to go through an accreditation process. You've got way too many other things keeping you busy. But what accreditation does, like JCAHO or any other form of accreditation, is to hold you to certain standards. And so that's a system way of doing it. And I really have to say that I hope someday there's a process whereby all primary care clinics, no matter how small, meet the system quality standards that should be there. And the 5th one is this idea that personal interventions are non-punitive. So, we all, I will tell you that I'd love to say that I never make mistakes, but sometimes I do, and I suspect you all do too. And there's a lot of evidence that if we make what we do about people's errors non-punitive, in other words, not punish them, but instead make it a learning opportunity and be grateful that we caught it before it became life-threatening, that people are more likely to reveal their errors and learn from them. And so that's an important, it's just getting away from the focus on the individual and putting the focus on the system. Okay, now this is one of my favorite slides, and just take some time to look at this. It's a really brilliant slide about that you have to take some time to understand about how errors are made. And the whole point is that on the left there you see triggers in the world. And think about it as your clinic. And you do something. You check a patient in, and a patient has their vital signs taken and is put into the room. And they go through all these different steps. And the point is, all of these things at the top are things that could cause mistakes. Like there's an incomplete procedure, like you have a patient with asthma and you don't collect or check the peak flows. There's a mixed message. So you tell a patient to come in at 2:30 on the 5th and they think it's 2:30 on the 6th. There's a responsibility shifting is things like a transition from one person to the next. You're not properly trained well. Your attention is distracted. The technology doesn't work. All of these are possibilities for error. And at the bottom are ways that we prevent error. The institution has rules, the organization has rules, the profession trains you in a particular way, the team has rules, the individual and the technology. And the point of the slide is that if you've got the right kind of redundancies and protections in place, you should have as few accidents as possible, because it requires all of these holes to match up for an accident actually to happen. And so you can see where, there's a place here where something happens and it doesn't match up. I'm not saying that very clearly, but it's a slide you sort of have to study, so don't spend too much time obsessing on it. But I do think it does show you, we talk about the idea of the Swiss cheese model, which is that if the system is set up right, you have fewer and fewer errors, because it takes so much work for all the holes to line up for an error to happen. I hope that makes some sense. I mentioned earlier the second thing besides systems is interdisciplinary team. Clinicians and institutions, as it says here, should actively collaborate, communicate to assure exchange of information and coordination of care. I work in a clinic now with medical students and nursing students and nurse practitioners and physicians and medical technologists, now called clinical laboratory scientists. We all have a role. The clerk has a role, the medical assistant has a role, and it's all about being part of a team. And, everybody has the right to call somebody else on, I'm concerned about this, or are you sure that's what you want, or to help somebody out. And so it's really where we're trying to go in healthcare. And I remember years ago a physician saying to me, I was coming back into the room, I poured a med, and I'd gone to take it to a patient, and the patient questioned it, and I came back and was double checking, and I said something, and the physician said to me, well, you should have just said that you're the nurse and you know what you're doing. And I said, no, I shouldn't. The patient was asking a question, and I came back to double check, and in fact the patient had been correct. He knew his meds, and I had poured the wrong dose. And so we have to be part of a team and never just say, well, I'm so-and-so and therefore I'm right. And then it's all about the data, and we'll spend a lot more time in the next several months talking about data. But I want to start by just talking about the three categories of data that we'll talk about in terms of how we know whether we're doing well or not. And look at the data you're getting from the project and see what you're getting in the way of outcomes, process, and balancing data. I actually don't have much access or any access to that data, so I don't know what you're getting. But there's three kinds of data sets. One is outcomes, and this is information about the patient or the population that you're serving or the community. And it generally reflects health status, such as a group of patients' A1Cs or their blood pressure or whether or not they're smokers. The second set of data are process data, which are system data regarding the activities of the process. And I talked about this a few minutes ago. The idea of the quality of care is what they usually indicate, like wait times in the waiting room, lead times for the next appointment, how far out is your next appointment, how quickly do you get a phone call back to a patient who has a question. Those kind of things are process, and these are system data about how well you're doing the care. Another thing is, are patients getting foot checks, the diabetic patients, and are they being documented? And then the third category of data are what is called balancing data, and this is information about how well the system is functioning. And this is things like ER utilization, access to care, but it's also patient satisfaction is probably the most common balancing data. How happy are people with what you're doing? So I want to move right into some ideas about how we measure quality. And we talked about some lack of quality when I talked about the Commonwealth data and also about that ARC data, like the idea that people weren't being checked for their, I can't remember what it was now, but quality data. So let's talk about a safety. I've got several examples, because remember, care is supposed to be safe, effective, timely, etc. And so these are quality measures based on those markers, those Institute of Medicine aims. So here's an example. The percent of adults 65 and over with at least one prescription from 33 medications that are inappropriate. And the Agency for Healthcare Quality and Research and several other people have 33 meds that they've identified that no adult over the age of 65 should be taking. For example, benzodiazepines. And so that's a safety issue because it puts them at significant risk for falls. And so that's a measure of quality, is what percent of the patients in this nursing home, let's say, who have a prescription for at least one of these 33 medications that are inappropriate. Here's a couple of examples of effectiveness measures. And so these are the percentage of women over 40 who had a mammogram in the last 2 years. This is probably kind of an old number because, they came out with that stuff about being over 50, but who had a mammogram in the last 2 years. And so that's how effective is the healthcare system. The percentage of smokers who receive advice to quit smoking. How often do your smokers, when they come in, do you ask them if they smoke? And if they say yes, do you say, which you should, which is the standard, you need to stop smoking, how can I help you? You don't have to nag them or anything, you just ask them, do you smoke? Yes, how much? You need to stop, how can I help you? It's not punitive, it's just I'm here to help you, are you ready yet? Here are a couple of examples of healthcare utilization. Admission to the hospital for the purpose of hypertension. The admission to the hospital with a diagnosis of hypertension is considered avoidable. There's generally no acceptable reason for a person to be admitted to the hospital with a primary diagnosis of hypertension. And then the adults over the age of 18 who received outpatient mental health treatment or counseling in the last year. And because those are underutilized services. So those are just examples of measures, ways that we can measure healthcare outcomes. Here's a couple of access to care measures, the percent of people in fair or poor health who have a specific source of ongoing care. What this means is that when you ask people what their health is, and then later on you ask them, do you have a primary care provider or a healthcare home, and let's say they say their health is poor or fair, and then they answer no to healthcare home. That means that they don't have a healthcare home, they're in poor health, and so they have limited access to care. And the percentage of people unable to receive or delay received prescriptions due to financial or insurance reasons. I don't know about you all, and I hope that you're really good at this, but when I give prescriptions to patients, and of course I'm so grateful that we now have $4 prescriptions, and I live in a community where we have lots of pharmacies that give those. But, I never give a prescription to a patient without letting them know how much it's going to cost and asking them if they're going to be able to purchase it. And it's just there's no point in writing a prescription if you can't follow through with the patient's ability to access the medication. Remember, another one of the measures was patient-centeredness, and so here's an example. The percent of patients, adults, who report that their healthcare provider always listens carefully, explains things clearly, is respectful, and spends enough time with them. And there are surveys that are done every year by the federal government and organizations like Commonwealth Fund that just call people and ask them these questions, and the numbers are sadly not as high as you would like. In fact, let me look at that Commonwealth. I don't think I have information from Commonwealth about that, but it's a pretty low number of people who answer yes to this question. So ask yourself, how are you doing with that? I work in a very different world than you all do. I'm in a small community near a large community. I'm certainly not rural the way you all are, but I work like you do with a very vulnerable population of people. My population of services uninsured adults who have chronic health problems. And so I know all about health disparities, and because you all are in very rural practices, you all know about health disparities too, and your patients have disparities for two reasons. One, like mine, they're very poor, and then unlike mine, they have a long way to go. I mean, you're not there very often, and there's problems with access to care just because of distance and time. But one of the things that I'm passionate about is eliminating health disparities, and here are some examples of health disparities. And effectiveness, the children aged 19 to 35 months who have received all their recommended vaccinations. Patient safety, again, the elders with the potentially inappropriate medications, and then the percentage of people who are uninsured in an entire year. My patients are all uninsured, and so it's really, but being insured does not mean, as you well know, that you have access to care, because your patients could be insured and be 100 miles away from the nearest healthcare provider. So there's many ways in which you can have limited access to care, or the provider doesn't speak the same language or doesn't understand you, or there's lots of barriers to access besides insurance. So as I mentioned, this was just an overview, and I hope that by the end of the presentation you understood that we have problems with quality in this country, that some of the quality things are not just about getting the right medication or the right treatment, but about things like patient-centeredness and effective care and preventive care. I'd like to, at the end of each of these talks, I'm going to give you all a little assignment. This is actually your smallest assignment. All the others will be a little bit longer. But I want you to look at your practice as a group. Once you've all listened to this presentation, spend a couple minutes saying, what do I think are 2 or 3 aspects of my practice where you're not doing as well as you think you should? For example, how long it takes to get an appointment, or how often you ask patients about smoking. And write those down and do it as a team so that you come to some agreement about those 2 to 3 things, because you may not all agree about it. But I'm hoping the front desk person and the financial person and the coder, biller, whatever you've got, that everybody is involved in this decision, and talk to the providers, see if they agree with you. In my practice, I'm never happy about the level of A1Cs because it's such a challenge. I don't have enough providers. You probably don't either. And if I had enough providers, I wouldn't have enough support staff for my providers. So in the next time we talk, I'm going to talk in much more detail about how you can then address those problems, set some goals, and do some interventions. And then later on, we'll be even more detailed about ways that you could do interventions, and I'll have you send some things to me, and I can email you, or whatever way works best for you. Email's best for me, and I suspect it's good for you all, that we can go back and forth with some assignments to work on this. I'm doing exactly the same thing with a third-year medical student who's getting an MPH right now, so we're meeting this month to start a little team to work on something like this in my practice. So I'll share my experiences in this little new clinic that I have. It's not little anymore, but my new clinic, as you all are sharing your experiences with me. So thank you very much for your time and listening, and I hope you have a great day.